We started the recording. Good night, good evening, everyone, and welcome to our November IPHA Member Town Hall. And we're going to go ahead and get right started. As we've done in past town hall meetings, we have a CE presenter tonight, and I will turn it right over to Chris Herndon from Southern Illinois University Edwardsville School of Pharmacy to take us through this evening's topic.
Okay, are you all able to hear me all right?
We can, you're good to go.
Okay, well, thank you very much for having me as a guest this evening. I really appreciate it. This is kind of a hodgepodge of topics. And what I saw when I was asked to do this, because the original person, I guess, had a prior conflict, was they were looking for somebody to provide some personal background on what COVID is all about. Not all the, fancy secret serums that are used to treat it and all of that, but what are people experiencing? And so I am, I guess, about 5 months past my personal run with COVID. It wasn't fun, and I'm going to go through and talk a little bit about kind of what my experiences have been, and also what they continue to be, even up to now. And then this was my opportunity as well to have a somewhat of a restrained audience where I could get on my soapbox about the effects that this pandemic has had on patients in our state and in our neighboring states that either are on chronic opioid therapy for chronic pain or for opioid use disorder, and some of the barriers that they are experiencing because of this. So let's see if I can get this to work. I have nothing to disclose, unfortunately. If any of you all would like to give me some conflicts of interest, I'd be happy to accept. I was told that I needed a pre-assessment question because this is CE. So since the beginning of COVID-19, opioid overdose deaths have A, increased, B, decreased, or C, stayed the same. Pick your answer in the back of your mind, and we'll go on. How long do I have, by the way?
You got about 20, 25 minutes, however much time you need.
Oh, well, I planned for 5, so this will go great. So these are our learning objectives. I have to admit that when you look up the term long COVID syndrome in the medical literature right now, there really isn't a good consensus on what that really means. And probably the most recent review article I was able to find just recently published is that it may actually be 4 distinct subgroups, or what we call symptom clusters, in which people tend to, okay, if you have residual symptoms, you tend to be either this group of symptoms or this group of symptoms or this group of symptoms, instead of this big kind of hodgepodge of what all is going on. And it also looks to me like the severity of the symptoms when you were originally diagnosed really plays a pretty significant role in what those residual symptoms may look like. So if it's okay with you all, I'm going to start with really what the impact of COVID has been on a lot of the patients that I've been taking care of in clinic, and then we'll talk about the boring personal stuff towards the end. Okay, so this is data that was just released actually Monday from the St. Louis County Health Department. And I know St. Louis and we're Illinois, but what I'd like to draw your attention to is basically the overall city and county, okay? And this is opioid overdose deaths. And what we're looking at here is total changes. We can dive into the unfortunate and gender differences, but if you look at the January to June 2019 and 2020 count. And so this really, I think, makes a pretty good picture of, we really started to get kind of knee deep in this hot mess of a train wreck right around February timeframe. And what we're showing is a 53% increase time over time from the same time period last year in opioid overdose deaths, 53%. And the thing that really is concerning to me, if you look down here at the different percent changes when you tease this out from a demographic standpoint, is that our African-American patients in St. Louis City and County had a 64% increase in opioid overdose deaths year over year. And while Caucasian patients definitely did not, were not able to sit out this increase, it was significantly less. And so, and I want to put some, I guess, some perspective around this, in that what I am seeing, at least personally in practice, is that a lot of our patients that were previously well controlled on medication for opioid use disorder, or were in treatment and successfully going through the steps. I've had patients that have lost their employment, and that has served as a trigger to return to use. I've seen patients who have had a significant increase in their underlying mental health disorder severity, which has pushed them back to use. Knock on wood, I have not had any personal OUD patients that have added to this data, thank goodness, but I am seeing the struggles from these folks. And there's this constant tug of war now between what the federal government has done for us in terms of the DEA and allowing us to initiate these important life-saving medications for patients who do have opioid use disorder without an initial face-to-face visit. A lot of our providers in the community are not necessarily utilizing that relaxation in the regulations, as well as have not relaxed their monitoring requirements, to where a patient has to come in every week to get a urine drug screen and to get their meds filled, et cetera. So I apologize if this is a little soapboxy, but I do want to make sure that everybody is aware of these issues. And I would say there is a lot of misperceptions around potential regulatory repercussions from both our pharmacy colleagues as well as the prescribers. It seems like we've continued to get a lot of pushback, especially around prescription opioids, and some of our corporate colleagues, some of the state regulatory issues that may be misinterpreted, and frankly from some of our third-party payers that are driving a lot of this risk mitigation. We simply cannot test these folks for drug toxicology, and that creates a lot of, I think, anxiety around prescribers, especially considering some of the relinquishing of DEA licenses that have been occurring recently in the news. A lot of these patients have lost their cars. They can't get there. They're scared to death to get on public transportation. So there's a lot of issues and barriers around taking care of these folks. And frankly, I don't know how you all are dealing with this, but I have seen a huge uptick in just the general resting level of anxiety around people being pent up in their houses, quarantines. My younger son, who's a freshman in high school, had to be picked up from school yesterday because he was on the bus with a kid that tested positive, and now he's at home for 2 weeks, and that raises my anxiety because then I've got to deal with him and clean up after him and smell him all day long, right, while I'm in quarantine. And frankly, what I think I'm seeing too is there's definitely compassion fatigue going on right now. And I know that it's tough, and I applaud all of you who are on the front lines continuing to take care of these patients and doing your job. And then last but not least, and one that's been difficult for us and for me, is provider quarantine. You know, if patients are used to getting their medications from one particular person that really knows their ins and outs, and that person is quarantined, that can really wreak some havoc on their ongoing care. So before I move on to long COVID syndrome, does anyone have anything to add, or you know, throw their own personal issues in on this? I know this is kind of a controversial topic at this point in time, and unfortunately I've been seeing some definite bipartisan, I would call it bipartisan approaches to the care of patients who require limited drug supply at a time and testing. But Garth would probably murder me if I turn this into a political discussion, but I'd welcome any comments you might have.
I'm just going to read the chat box. I said when you were back there, I just added the male numbers, the increase of if you were a male gender in your display. And then Dave Micas asked, what are the differences between the street drug death and the RX drug deaths? Are those only RX drugs?
Okay, so I figured out how to pull the chat up, but thank you, Starlin, I appreciate it. From the street drug and prescription drug deaths, frankly, the prescription overdose drug deaths, we don't even really talk about anymore. It's so low. Really, when you see opioid overdose death rates now, you're really looking at fentanyl and its analogs, or heroin, frankly. It's really tough to tease out the prescription versus non-prescription, but really when you really dive into data at the state level, I mean, it's a very small proportion comparatively. As that spike continues to rise, really the bulk of it is, I guess, what you would call illicit or synthetic opioids. Because remember, I mean, in Illinois, we've cut our opioid prescription numbers by dang near 50% over the last 5 or 6 years. So it's not out there in the community as frequently as it was, and certainly not in the doses. Anxiety, yes, definitely. Are you seeing more prescribing of benzodiazepines? I personally am not, but frankly, we are going to be having a PMP meeting, I think, in the next week or two to review all of this data. I'll be surprised to see it and happy to share that information with you once I see it. I have not heard of a huge uptick in benzo prescribing, but Cindy is, and she's saying at her site that there is a lot more prescribing. I've been asked if there's any opioid drug shortages. I don't know. That's a good question. I don't know, with the exception of some of the more unique opioids that we frequently use in our practice. We've been having difficulty getting levorphanol at some of the pharmacies. I know that for a very short period of time, there was some difficulty with the controlled release tapentadol. I'm wondering if it's truly manufacturing shortages of these meds or just delivery, what's the word I'm looking for? Delays in getting them in. We are counting on 1 to 2 days versus the previous, hey, if you can get the prescription in by X time, they'll have it the next morning. I have seen a couple instances where we've had difficulty getting the higher dose Suboxone film. I don't know if that's from a back order or not. ASHP does not have it listed as a current drug shortage. I know that there are intermittent parenteral opioid drug shortages that we're dealing with. I'll praise the Lamb, difficult to get. Would you be able to share how your clinic has updated any policy protocols during the pandemic? Well, with the exception of probably what a lot of you all are doing as well, at first we really went heavy into phone and telehealth. Our clinic has started to pull back from that as a health system where they're trying to target certain numbers of face-to-face versus telehealth. And it's really been provider specific. Like I said, there tends to be some folks who, felt like, hey, life needs to go on and you and your patients need to come into the clinic. And there are others that have been very understanding and compassionate about people who are scared, who may have an immunocompromised state. But to my knowledge, and I think Dr. Rosselli is on the web call as well, who I share an office with, if any policies that she knows of have changed. But other than that, we've been trying to just follow CDC and IDPH policies and regulations. Okay. I feel like I pretty successfully skirted everybody's question and didn't really give anybody a straight answer. Hopefully this, never mind, I was going to make a political joke. Okay. So anything else around this? So I'm seeing some difficulty with benzodiazepines being used, or at least received. Are people finding in you all's practices that you're hearing from patients that this is become a really big difficulty from them health-wise? A, and B, I'd be curious to know how many of you all have people coming in that you ask, hey, do you have a temperature? Do you have any symptoms? And they say no, and then hack and cough in front of you for like 10 minutes straight. I get that all the time. So Dr. LeCarry is curious about how we get anything done, and that is true. Dr. Rosselli and I do share an office, so that almost makes me famous given her stature. However, she won't come in on days that I'm there. So I think that's probably makes me not an assistant manager, but an assistant to the manager, if that makes any sense. Okay, let's move on. So the other thing I wanted to talk about was long COVID syndrome. Like I said, we don't really know what this is at this point in time. I'll share my personal experiences with you. So I never had a fever. I came back from July 4th weekend and thought I had a sinus infection. And so because of that, I got a little bit worried given everything going on, but felt like it was nothing. But I stayed kind of on my own side of the house and stayed away from everybody. And things kind of fell off the tracks over the next couple of days from a health standpoint. And I was able to crawl to the clinic and get tested, and it came back positive. So I personally was down for the count probably for about a week, maybe a week and a half. I never had a fever. I really didn't have a cough or chest pain, but it felt like people were ripping my muscles off my bones. I'd get up, take a shower, be exhausted, have to go back to bed for a nap. And then when I did get up and was able to get some work done, I was able to go till about noon, and then had to go back to bed just because I was so tired. And then gradually that improved until I was able to make it till about 5 o'clock. And then I went back to work and started getting the students back involved in everything. I will tell you that my symptoms have not gone away. They are obviously much better, but I still get really bad myalgias kind of intermittently. I used to be a night owl and would watch TV until 2 a.m. I'm done asleep. Actually, it's almost my bedtime, so we better speed things up. And that's just, I don't know if that's the new normal or if that's the way things are going to go. We don't have any long-term data past like 6 months, obviously, that's been published up to this point. But I will tell you that the unequivocal information that is out there seems to be pointing to it's going to be around a bit. Over half of the people that had their follow-up appointment after testing positive actually had residual symptoms based off this recent study published in MMWR. And then this is an interesting one from a different publication, but same author. And basically what you're looking at is this light blue line are symptoms that were reported when these patients tested positive. So if you'll notice, when you walk in and everybody's testing you for a fever, only about 60% of people actually have the fever. The most common symptom that people are describing at diagnosis is fatigue, followed by cough, headache, body aches. You'll notice chills, loss of taste or smell, while definitely that has become kind of the poster child symptom of this disorder, really is just over half of the patients. Diarrhea, congestion, dyspnea or shortness of breath. And the other thing that we're finding too is that there is some cardiac or cardiomyopathy type situations that a lot of our inpatient colleagues are dealing with that is presenting further down the line, and they're not really sure. It tends to be isolated in people that were on the vent and in the hospital, but these blue lines represent the frequency reported at testing. But what I really want you to focus your attention on is the blue line, and this is unresolved by interview date. Now, my understanding is that the bulk of these patients were interviewed sometime between 2 weeks and 3 weeks after positive confirmation. So again, does this represent long COVID syndrome or not? I would tend to say no, personally, but I mean, when you look at the percent of patients that continue to have these symptoms, even after theoretical, pretty amazing. And the thing that strikes me when you look at some of these is, for instance, the cough tends to have a really high, when you compare at diagnosis versus 3 weeks later, cough tends to be pretty close to creeping up there. Congestion, dyspnea, chest pain, confusion even, believe it or not, and this is one that I'm embarrassed to say and I don't want to hear any cracks about, is I tend to find that I'm having some word finding difficulties that were not there before. At least I don't think they were, that weren't there when I was diagnosed, and now I find myself kind of stuttering along when I'm speaking, trying to grab the word and find it. My wife would definitely attest to an increase in confusion and probably even hearing issues based on what she claims. Let's see, I've got some comments. I'm having symptoms. This stresses us out in the pharmacy. I agree. Confusion symptoms go up as time goes on, from Jenny. That's what this data shows. I'm an N01, but I would agree with that based on my experiences. As far as the mask stuff, I don't even want to go there. That's just well, we'll argue about that later. Anyway, one more set of data that I thought, this was from a study, hot off the press, from some investigators from Canada. If you can see what we're basically looking at, let me move my little boxes out of the way, is this is acute, this is post-COVID follow-up. This was again around 3 weeks that they followed up, so definitely not what we would hope to see. It much mirrors what MWR reported. When we come down, I don't see the confusion on here, but their numbers are pretty close with the exception of myalgia is reported a lot higher in the US. So this is what we know so far. And honestly, we know very little. We're going to get completely back to normal. I don't know what these symptoms mean in terms of return to work, how long quarantine should last. Is this going to be like the old mononucleosis picture where you're basically shot for 6 months after you have it? It's tough to tell. But most potentially concerning for all of us is one very little discussed symptom of COVID, and that's hair loss. As you can see, I've already experienced COVID-related hair loss. It's very debilitating. It's preferential for the top of the head, and the shower drain has really been having a tough time with this particular COVID-related long-term side effect. So, all right. Well, hopefully you guys, I'm right at 30 minutes. Hopefully you guys heard something you hadn't heard before. Why did this leave? Okay, so what did you learn? Since the beginning of COVID-19, opioid overdose deaths have A, increased, B, decreased, or C, stayed the same. The obvious answer, A. And the reason that I find it important to discuss this with you all this evening is please be vigilant in your practices about patients that you have any suspicion of being at risk. This is the time more than ever that we need to have a conveyor belt of naloxone going out. We need to be utilizing Espert in these patients because they really are at higher risk now more than ever. So in conclusion, don't get COVID. All right, I don't have any references other than that are on this slide. So I will stop that, take any questions that weren't already mentioned or any complaints.
I think the only other question, Chris, was any guidance yet about use of anticoagulants after patients hospitalized for COVID or discharged?
I would be willing to bet there are better people on this webinar to address that than I am. This actually came up as a question today. I don't have the answer. Since I share an office with the lady that asked the question, I'll be happy to do a thorough literature review and leave a drug information response on her desk for her to read when she comes back in. Does anyone else on know?
Any other questions or comments?
So are you seeing this prescribed at discharge? Are you, Dr. Rosselli, are you referring to people who are on anticoagulation as a result of their COVID diagnosis in the hospital and then are being sent home on it? Is that?
Yeah.
Okay.
Yeah, I'm just curious if those prescriptions are getting sent on discharge and if that seems to be more of the practice now that if they do survive COVID, then once they go home, are they extending any anticoagulation for those folks?
I will look it up for you quickly and get back to you momentarily.
I'm not trying to pimp you, I promise. I just am curious about this issue because we know that people, a lot of times it's the clots that are killing people. So just curious what's happening in practice with that.
Okay, well, I will turn it back over to you, Garth. Thanks.
Okay, thank you. And I'm going to pause the recording here for a second. All right, we'll start the recording. I do want to take the rest of the time this evening to kind of review a couple of our normal COVID statistics. I'm not going to spend a lot of time. I know a lot of people know what's going on in Illinois, but I do want to take some time this evening to go over the election results and kind of how that impacts pharmacy, and particularly here in Illinois. And we won't be getting too much on the biggest race, but we'll be talking about all the other stuff that hasn't been talked about as much on the media. So first, I want to bring up, let's see here. Bear with me 1 second. All right, as we all know, Illinois is kind of on fire when it comes to COVID again. And all regions, all 11 regions, as you remember, Illinois did try to help regionalize this, so not all the state was under the same mitigations at once. And we are now seeing a statewide positivity rate of 8.5. And so we've been above 8, and 8's what triggers the mitigation measures. And as we all know, we're all 11 regions are now in tier 1, except for region 1, which is the northwest corner of the state. They are now in region 2. More than likely, they will be proceeding at some time this week to probably tier 3 mitigations. And so I know we haven't really talked about what those different mitigation levels are, but I did want to go through those with you real quick, just to kind of show you what happens. As we know, if it's a sustained increase in 7-day rolling average, either the positivity rate or of hospital admissions, or if the reduction in hospital capacity gets below 20%, it does trigger the mitigation measures. And that's why most of us are in tier 1. But as you see here, if you go on the state's website under the public health coronavirus website, they do have what the tier 1 regulations are. And it's also a good review place because most people think it's just restaurants and bars, but it also impacts hospitals. If we get up to tier 3, they'll have to suspend elective surgeries again. There are limitations on meetings and social events. There's limitations on some offices promoting, work from home. And if we get to tier 3 mitigations, again, we go back to only essential retail services. So we thought we've had issues with the restaurants and business and bars. We may end up having to basically go back to phase 2 measures that we were under and back in April and May, because right now we're seeing caseloads that are a lot higher than what we were seeing back earlier in the year. And as you see, we've had 7,500 cases today. We did have a hot zone map, but guess what? We're all one color, not the color we want to be. And so as we said, the entire state is increasing. Again, as we've been talking about through Facebook and other social media, please continue to try to protect your pharmacies the best that you can. If you can screen patients, please do that. If you feel like you need to go back to where you were in March and April of just doing closing your lobbies and offering delivery and drive-through, it may be time to consider those actions again, and just trying to help protect your pharmacy staff and your patients. As we see nationwide, we're at 9.5 million cases. I still like to show the recovered. I think we need to be focusing more and more on the recovered, that we've had almost 32 million cases of the almost 48 million are recovered cases. I do want to hit on one other thing that's happened since the last time we were all together. and that was on October, I believe, the 21st. HHS issued out yet another amendment expanding authority for pharmacy. And this one was directed specifically at student pharmacists and technicians. And it was more of a clarification for student pharmacists, but for technicians, and allowing those that have been properly trained through an ACPE course and have completed 2 hours of additional CE, that they can assist in providing and administering immunizations. Now, of course, this doesn't really change much of what we were allowing or have moved to allow here in Illinois. We were already on this. We moved for language for this back in January, and we've been working on the rules, which, as we've talked before, the department's been kind of slow rolling that, and we've been pushing both ICHP, IPHA, and IRMA have been asking for the department to consider requesting to the governor's office for the immunization administrative rules to go to emergency status so that they could be quickly be implemented. And we're still waiting on that. And so hopefully here soon, there's a Board of Pharmacy meeting here coming up next week. It'll be interesting to see, because I know this will be of discussion. We also are encouraging the governor's office and the department to issue a statewide proclamation mirroring the HHS expansions of scope for pharmacists. We don't necessarily need that, depending on which lawyer you talk to, but it would be helpful to have that state level of recognition that they want pharmacists to be able to prescribe and administer these vaccines as we get ready for them. Because as we know, we continue to get ready with for the COVID vaccine, and there'll be more information coming out. Again, if you are not registered with iCare, please do that. We're going to be pulling together some resources for you, for not only for iCare, but Vaccine Finder, which you'll also need to be required to be a part of to be able to receive the COVID vaccine, and for record keeping. And I think that's all I want to give on COVID. I know we all know what's going on right now. We all need to be more and more vigilant to protect ourselves, because what we're seeing is that healthcare providers are actually being infected outside of their practices. So, then inside their practices and from their exposure from their patients. So, just be very vigilant when you're out and about. And if not, any questions on that before I switch over to the election?
Garth,
Yes.
has anybody got any information on probably the demographics of hospitalizations? Are they any different than they were the first 2 or 3 months that we're on? And is the length of stay better or worse than it was?
I know hospitalizations for Illinois have increased. I don't know about lengths of stay. If anyone else on the call can comment to that, please do. But I do know that hospitalizations are definitely on an increase in Illinois right now.
Hey, Garth, I have a question for you.
Go for it, Cody.
So in addition to the VaxFinder and iCare, do we need to get registered on VTrax through the CDC as well?
That's a good question, and something that we're waiting to get an answer on. I know some health systems are going to be required to, and that may be why you're filling out information on that. And some of the chains, national chains, may be using that, but we're not sure if some of the critical care hospitals or if independent pharmacies will have to do that because they're smaller practices.
Gotcha. I guess I just wonder, if we do end up registering with that, is there any integration with iCares? So
that's something we've been told that data is supposed to be shared, but again, that's a lot of guessing and things, saying that we're hoping it works.
Gotcha.
And Miranda, you asked a good question about when registering for iCare, who do we put for portal registration authority? And I'll get back with you on that one. I'll have to look that one up this evening. Laura, you put, my understanding is that length of stay is now shorter. And I would agree with that to an extent, because I think we definitely know how to attack this better when we're seeing inpatient than we did before. Dennis, you had your hand raised, so go right ahead. You're unmuted.
Just a clarification on the vaccination rules, especially of getting the technicians involved now.
Yeah.
Once they've been certified and all that, I believe the rules say that there has to be direct supervision of a pharmacist. Is that correct?
That is correct.
Okay, if you're a telepharmacy though, the pharmacist watching what you're doing over a TV link, is that acceptable?
That's something we're going to ask because, believe me, I've already had the horror idea in my head that we could have technicians with body cams. That's how we're going to be remotely administering and reviewing their supervision. So, especially when you have a certain chain out there saying they're hiring 10,000 technicians, but they don't have enough pharmacists to be able to handle their normal Monday through Friday business right now. The definition of supervision definitely has to be tightened down when we start to look at getting ready for COVID vaccine.
Yep. We're thinking along the same lines.
Yep. All right, everybody. I'm going to switch over to talk about the election, and just right now, I'll just tell everybody first thing: breathe. We're going to be okay. We're going to get through this. So let's see here. So with the election, of course, you know, this is the big topic for the last couple of months, and we've been definitely discussing it over the. Is everyone seeing the PowerPoint or the actual PowerPoint or the actual PowerPoint window?
I see something that says national.
Okay, and that's the only thing you see. You don't see like it's my editing screen for PowerPoint.
Correct.
Okay,
Just
good. Thank
the
you.
national slide
Cool.
clean.
All right, great. Thank you. So I always like to start off with a little bit of humor in some of this. And so this is exactly what we know so far when we come to the election. We definitely was a roller coaster last night. I think for some of us, there was a lot of changes, but I hate to say that sometimes politics is sometimes a lot of the same. And I think that's what we were kind of seeing last night. This is what we're seeing at the moment that former Vice President Biden has been able to secure 264 electoral vote possibilities, with President Trump securing at the moment 214. We know that there's already been discussions about recounts in court cases. So we also have long ballot time windows like in Illinois. Illinois is a great example. We weren't, of course, one of these battleground states. We were a safe Biden state, so we didn't get a lot of attention. But you could have your ballot in the mail as of yesterday, as long as it's received within the next 2 weeks, it can still be open and counted. And so there are other states that have similar language. So and most states don't even really certify their elections until about 30 days after the fact. So we really won't be seeing any really true official election results until the end of the month in the first part of December. And remember that the Electoral College doesn't meet until December 14th, and that Congress doesn't officially accept the results of the Electoral College until January 6th. So we still have a lot of weeks and days ahead of us where we may still have some questions about where we are with the election. And Dave, you have your hand raised, so go ahead and unmute yourself.
Okay.
I'm trying to get my mouse over there too. There you go.
Now, those new legislation, we may only be able to talk about Illinois. Was that an executive order, or was that legislatively driven? Because the legislature supposedly is the only one that can change election rules. Is that true?
What was your question? I'm sorry, on which part of it?
On 2 weeks later, as long as they were post dated by yesterday, was that?
Oh, that's been established Illinois law. That wasn't anything because of COVID. So Illinois law has been that way. I mean, Illinois, if you really look at it, we're very open. You can vote pretty much 45 days before the election. Ever since September 24th, you could start to mail about a request to mail ballot and send it back in, or go in an early vote. So some states didn't even do early voting until the week prior, or even a couple days prior. So Illinois is really kind of on the game. And I think that's where we haven't really seen a lot of problems here. The only thing I've really seen here is some people in Chicago complaining about what they were calling Sharpie Gate, that some of the pens being used may be bleeding through the bubbles, but I really don't think it's caused a problem. I saw an article clarifying it from the Illinois Board of Elections, saying that that seems to be more of a problem in Arizona, which who knows how that's going to turn out and be a player. We now have our new hanging Chad for 2020, but it is not an issue for the Illinois election. But for congressional delegations, Senator Durbin is reelected to his 5th term. When it comes to the House, it's retained control, at least at the moment, of 12 of their 13 seats. When it comes, and the Republicans retained control of all 5 of their seats, and possibly gained 1 seat with the 14th district, with incumbent Lauren Underwood may not have won re-election. It is a very tight race, as you see, less than 1,000. I'm sure there will be a recount. We will definitely be seeing how that all plays out here in the coming weeks, but I have not heard of any place where to any place where she's conceded, and anyone can correct me if I'm wrong on that part of it. So let's move closer to home and talk about the General Assembly, which has the greatest impact on our Practice Act. The Democrats in the Senate, let's talk about the Senate first. The Democrats retained all of their seats for now. And if you look up here, District 10, this is, there's still 165 of 166 precincts have reported, and I pulled this about 5:30. And Senator Martwick, who's the incumbent, is barely keeping his seat with 27 votes right now. This was going back and forth all night. We'll see what that says, where it goes. But if that does, it means that the Republicans would gain 1 more seat. But as we know, the Democrats would still have a supermajority. The Democrats retain their supermajority in the Senate and in the House in Illinois. So it's not really going to really sway the position of power. But because of the Republicans not picking up a lot of seats, Leader Bill Brady has announced that he will step down as minority leader after this session, and he's not going to seek the leadership. Senator McConkey and Berrickman have already been 2 individuals that may be coming forward to take over that leadership position. So we'll see with those elections. Those will happen in January. So there's plenty of time for continued speculation and fundraising. These were the seats over here on the right-hand side of the elections. Karina Villa was a House member who ran for the Senate. Also, John Connor in the 43rd was also a representative who ran for the Senate. And also, of course, Darren Bailey, who has been a tremendous multi-spiked thorn in the governor's side, because he, along with Tom DeVore, have been filing the multiple lawsuits against the COVID vaccines, and he takes the place of Senator Dale Ryder's old seat. But we did have some unopposed races, and they were both Republicans. Wynn Stoller will replace Chuck Weaver for the 37th district, and Terry Bryant moves from the House and replaces Paul Schiff for the 58th district. Illinois House, we had a lot of close races. We had and a lot of people shifting around. We had a handful of representatives that some of them even 1 term that didn't run for re-election, which that's always interesting. You know, we get lifers when it comes to the General Assembly. So it's good to see some people understanding what term limits mean. But we have Democrats lost 4 seats. It's interesting, when all is said and done, the House Democrat caucus will be majority women for the 102nd General Assembly. So that is a major shift in demographics for the General Assembly in the next year, actually for the next 2-year cycle. The Republicans lost 2 seats, and it's interesting, in the 2 seats that they lost, they really shouldn't have, and it's very interesting. We did have some unopposed races. Both of them are Democrats, replacing people who had got primaried out, and that was Margaret Croak and Denise Stoneback were replacing people that they beat in the primary. When we look at the races here, the 41st race is interesting. Grant Worley was very narrowly defeated, and he was the assistant majority leader, assistant Republican leader. And so he definitely was a target. There were some additional Democratic targets that lost their elections, like in the 45th district, and also in the 51st district. And then the other Republican loss was Alan Skillicorn, who was a very vocal thorn in the side for the speaker throughout the entire his entire term. He didn't really campaign. Even at one point, he kind of abandoned it and then came back and tried to run again. So it was very interesting to see how that race ended up. And as we see over here, there's some other races for those in the district. So I did want to, if these were your districts, I did want you to at least be recognized of those who may have changed for you and who will be your new representatives. One thing that's interesting of note, the Illinois Pharmacy Political Action Committee did make some recommendations and contributions during this campaign season, and all the people that the Illinois Pharmacy Political Action Committee supported and chose to support won re-election. So all of our pro-pharmacy friends, and I say pro-pharmacy, they are not Republicans, they are not Democrats, they are both. We look at who is going to back us. I don't care if they're red, blue, yellow, or a green party. I don't care. If they're for pharmacy, they're on our side. And so we won when it comes to people that we support, people that we feel can help us get our mission accomplished. So let's continue to talk about pharmacy. This is going back on a national level. So I do want to talk about controlled substances. It's interesting. We had a major movement again. It's like if you looked at the election last night, you would have thought anti-drug policy would have not been a big moving issue, but it was. Despite what people were voting for president, or who they were voting for president, they definitely were being more progressive and pulling down the barriers of the war on drugs. And so we really only have 7 states now that have marijuana in some version as illegal. I don't know how many more states do we need before the federal government has to understand that they no longer have authority. And Cody, you were asking which representatives or senators were those in which part? I'm sorry, Cody. Oh, on pro-pharmacy, I can get you the list of everyone that we supported. Everything on the Oregon is an interesting situation because not only did they decide to legalize mushrooms, they decided we're going to go one step further and just decriminalize every drug, and we're going to become Portugal. We're going to take the Portugal model, try to support addiction services, and hopefully we'll see if this works. Because it could be something, it could be a good model for all other states to look at. Instead of punishing people for using substances that, whether it may be helpful for them or if it's just completely recreational. So again, we had major shifts last night when it comes to that. And then one other slide. Back in the U.S. House, Buddy Carter, who represents Georgia's 1st district and was the only pharmacist to represent us in Congress, was reelected. But he will now be joined by Diana Harshbarger from Tennessee's 1st district as the 2nd pharmacist. in Congress. So we've doubled the number of pharmacists in Congress. And I think, again, it doesn't matter if you support the party that they're from. We have pharmacists in Congress. And Buddy Carter will be the first one to tell you he doesn't care if he's talking to a Democrat or a Republican. He has worked hard to get himself on the committees that we need him on to help explain our issues and tell people what pharmacists can do and talk about the evils of the PBMs that we continue to battle each and every day. And Diana will be doing the exact same thing. She also comes from a community pharmacy background. So this is a huge win for pharmacy. And because it's just been stressful, I just want to put up a nice picture for everyone to kind of breathe and just relax for a moment. And just remember, it's going to be okay. We've got some really tough weeks ahead of us as we try to go through getting the election finalized, but we'll be okay. Any questions or comments? Oh, Hank, you've got a question. Let me unmute you here. Go ahead, Hank.
Got myself free.
All right.
Just to preface my comments, I belong to a senior citizens group up in the north suburban Chicago area. And there are a good number of people in that group that are convinced that I'm a vampire. I typically send out emails between the hours of 1:30 and 4:30 in the morning. And this is because I have a habit of going on television early, falling asleep, waking up, and then taking care of a few minor business things. Last night I started watching the returns at 9 o'clock. I fell asleep somewhere between 10:15, 10:30. I woke up at 1:45, and the announcers were saying, we are awaiting President Trump's appearance momentarily. And so when Trump appeared at 2 in the morning, I was wide awake watching. And first of all, he was in the Oval Office in the White House,
Eastern.
which is a violation of federal law.
Right.
The White House is not supposed to be used for political purposes under federal law. The second thing is, as Trump was preceded by his invited guests who filed into the room, sat down in the chairs, shoulder to shoulder, and then Trump and Pence and their immediate families were on the podium. Nobody in that room was wearing a mask. Just the point of his absolute defiance to good health practices, common sense. And then he proceeded to announce that he gave an analysis of each state that was undecided at that point and pointed out his projection for how that state had to be his. And after he went through every state, he said that since, according to his projections, he was the president, the following morning he was going to go into the Supreme Court and demand that the Supreme Court cancel all future voting because he had already obviously won. And that was the point at which I turned it off. And awaited today's results. But
Well, Hank, I understand your frustrations. Most of you who follow me on social media know that I had a couple things to say about the actions of the president, and just to remind him that we're a democratic republic and we have a constitution and we're not an authoritarian state yet. But, and that's why we have this process, and I'm glad the process is currently working at the moment. I think when all said and done, we will have a change for the country, and we'll see where this vision goes. So, Hank, thank you for sharing your viewpoints from last night's.
I was watching WGN TV, which had a panel of 8 individuals, Republican and Democrat, who were responding to the events as they occurred during the night. And one of the Republicans, who was a former state, he was the leader of the state Republican Party at one point in the not so distant past. And he apologized for Trump's comments as being unconstitutional, irrational, and he really could not humble himself any more than he did, trying to just get the distaste that he had for Trump's comments out.
Right. It was definitely an unpresidential moment last night, and we thought we've seen a lot of that in the past, and unfortunately we saw a new level last night. Abby, you've had your hand raised. Go right ahead. Oh, I think you go ahead, right ahead, Abby.
Thank you so much, Garth. And it's always challenging to go after Hank. He's very articulate. We love having you, Hank, when the students are on a Zoom. Speaking of having student, Garth, I was wondering if you can give tips to students who would like to be involved in advocating for pharmacy. What would your advice be for them when they're in school and once they're newly graduated? How would you encourage them and advise them to keep advocating for their pharmacy practice?
Well, the first thing is getting involved and being a member of IPHA, because that's the best way to keep active and keep up the knowledge of what's going on and how you can be an essential part of your practice. And I always like using the old NCPA model, and I'm glad to see it come back again this year, is get into politics or get out of pharmacy. Remember, as I talked about in the presentation tonight, the Illinois General Assembly has the most impact on your practice. They decide what the Illinois Pharmacy Practice Act looked like. And I know we put so much pressure on the Congress, but Congress really does not have a huge impact on us. Yes, they handle things with Medicare and some things with Medicaid, and they do impact us on provider status. But the everyday practice, 90%, if not 95, 98% of your everyday practice is handled by the Illinois Pharmacy Practice Act. And that's where, if you don't know who your senator is, you don't know who your representative is, you have to get involved. And I really encourage you to be part of these campaigns and help find people that are pro-pharmacy. And if you really have a real fire under you, let us know, and we can help consult you in ways of if you want to run for office. We need pharmacists in the General Assembly. It's been a long time since we've had pharmacists. We used to have pharmacists in the House and pharmacists in the Senate. And well, we had one in the governor's mansion, but we'll talk about that at some other time. And but we need more representation of healthcare providers in the General Assembly. We don't have any right now, and that's really what makes our job, and one of the reasons why it's so important for IPHA as a voice for pharmacy in Illinois to continue to build our voice with more members, because we need to continuing to educate the General Assembly. Most of our advocacy efforts is educating staff and educating the General Assembly on how all of these bills impact you and impact your patients. Hopefully, Abby, that was the short answer you wanted. Any other questions or comments? We're past 8 o'clock, and I do want to be respectful of everyone's time. I see Starlin, you've unmuted, so go right ahead.
So for the students, you never stop learning. Every year there are new drugs and there are new diseases and there's new ways to treat. And the same way with advocacy. For 23 years, I couldn't advocate because I was on contract as the quality assurance director for Medicaid, and I was a mole a mole for pharmacy, and I got to see what the internal system thinks of healthcare providers in general, and specifically a pharmacy. We're a bunch of complainers. We're not aggregate. We don't stick together. We come in and the first thing out of our mouth is that we're not getting paid enough. And yet when we ask you for documentation or show us where it's not, no one will voluntarily give that information. So you can't always complain and get what you want. And so in healthcare, we have to work together as a team, and we have to get other stakeholders to support us, like be nice to nurses because they get you in front of the doctor. And then as we work all together in this team, we'll support each other and maybe as a team get things going. But we've got to stick together. And just remember, health system pharmacists, you may see the patients for 7 days, and the people in the ambulatory community world see the patients for 365 days. So we all have to work together to make sure, because what we all have in common are patients. And so we also need to have the patients help us advocate for us. No one knows what we do for the patients. And if we don't tell their stories, they're not going to know our story. So we've got to come out from behind the counter and come out from behind the screens and tell our stories. And I'm on the PAC Board of Governors for IPHA, and registered dietitians who have the medical nutrition therapy clause for Medicare and gets paid and is a provider give 5 times more money in PAC money across the nation and advocacy money than pharmacists, and registered dietitian make between $35,000 and $45,000 a year. And what do pharmacists make? More than that. So I know people don't like PACs. I know they don't like advocacy money, but it is the way this, as you can tell, both sides spent millions of dollars this year in the election. Millions. Yeah, that put people to work, that paid for paper, that paid for a lot of things. But this country runs on economics, and the economics of it is if we really want something, we've got to pay for our place at the table. Right. So when your executive directors and the PAC challenge and the advocacy letters go out, when you join, you don't have to give $5,000. If every person, there are 15,000 pharmacists registered in Illinois. Imagine if everybody gave $1. IPHA and ICHP we'd have $30,000 to do things with. So it really is important that we give that. Now, I'm telling you, I was on the inside. We are not looked at as professional people. They think all we want, and unfortunately our corporate buddies out there portray us as money graveling non-professionals. We've got to work 3 times as hard to prove our worth. So write about what you do, document what you do. Write those articles, do those poster sessions, get out beyond pharmacy, go to a medical association meeting, go to a dietitian's meeting, go to a diabetes meeting, go somewhere else besides we love our little group here. I love everybody on this call, but we need to tell everybody else out there how cool Chris Herndon and Jenny Roselli and Laura Licari, all of you guys are great. And our patients wouldn't get anywhere without us. But nobody knows that. Now, I brag on you all the time, but we've got to brag on ourselves.
Right. Thank you, Sterling. And I saw in the chat we had a question about, has Illinois decided to move any legislation towards legalization of psychedelics? I have not seen anything, but it would not surprise me with the recent successes in Oregon and DC that we wouldn't see at least a bill filed. It'd be interesting to see what Illinois' approach would be on that. I think it'd be an interesting discussion. I know marijuana was a uphill battle with both sides of the aisle, and so it would be interesting to see what the future discussions of
Who's going to be in charge in Oregon of the psychedelics?
I have no idea.
I
don't
still
think-
think we as
I
chemists
think it's still going to be your local neighborhood dealer, and that doesn't. I don't mean that as pharmacists. So, but no, I agree. If we want, I think if there's going to be further legalization of medications, they need to go where they were before 1940, and that was at your actual neighborhood pharmacy, and so that we can properly consult patients on the safe use of all substances. And but that continues to be where we have to work hard and battle stigma. Any other questions for tonight? If not, we will adjourn for this evening and remind everyone that we'll be back on the first Wednesday for December.